Okay, hello, good evening, and welcome to tonight's My Macular and Me webinar. My name is Kathy Elf, and I'm the Chief Executive of the Macular Society. And as ever, it is absolutely brilliant and lovely to see so many people joining us tonight. Now, as ever, we have experts on hand this evening, but tonight we're handing the webinar pretty much over to you. So there is no specific talk or lecture tonight. We're not talking about one single aspect of macular degeneration. This session is for you to ask your questions of our two experts, one of them an optometrist, one of them an ophthalmologist. So firstly, let me introduce Rupal Morjaria, who is an ophthalmologist who specializes in cataract surgery and the treatment of macular degeneration and other diseases of the retina, such as diabetic eye disease, central serous retinopathy, retinal vein occlusions, and inherited retinal diseases, such as retinitis pigmentosa. She studied medicine originally at Birmingham University, but has also worked in Oxford and at Moorfields Eye Hospital in London. Her PhD was awarded for the work that she did on the impact of eye disease on a person's sleep-wake patterns, which is a very fascinating area of the impact of sight loss. So Rupal, good evening and welcome to you. Thank you very much indeed for joining us this evening.
Good evening.
And also with us then is Yuan Gao, who is an optometrist. He trained at Imperial College Healthcare Trust and his journey began in 2016 when he moved to the UK to study optometry at Anglia Ruskin University. He's also done some ophthalmology qualifications as well and gained lots of valuable experience working with opticians and volunteering at a low vision charity called CamSight. So he did, after completing his optometry degree, did further study in ophthalmology, and he was the first president of the UCL Ophthalmology and Vision Science Society. And he also has his own podcast because he's very keen in sharing his knowledge about eye health with the rest of the world. So Yuan, welcome to you as well. Thank you very much indeed for joining us. Your questions then tonight, if you would like to ask a question, we've had lots submitted already. You can use the chat function for your questions and we will, I promise, get to as many as we possibly can in the course of the evening. But we have some already, so I'm going to get going straight away. And the first question I want to ask you both is, what is the difference between an ophthalmologist and an optometrist? Now, who would like to start? Yuan, tell me, what does an optometrist do? Where do you fit in to eye care?
So I would say optometrist, usually patients in my clinic, they refer optometrist as optician. So most likely if you go to the optician, you do an eye examination, you'll be seeing an optometrist to check your eyes, to check the health of the eye. But in some cases, you will see optometrists working in a hospital as well, in some different clinics. So they're helping to see the patient in a hospital setting. But most of the optometry work in a primary care level. So basically, I normally say that optometrists are the GP. It's not very accurate, but I always say that optometrists are the GP for eyes. So if anyone has any problems with the eye, for example, you've got irritation eye, got some irritations or red eyes or anything you're concerned about your eye, which is not an emergency, I would say go to see your optometrist in the optician, and they can have a look of your eye and then see if there's a need to refer you, or they can manage you in the optician. So this is basically what we do as optometrists on the primary eye care level.
And most of them are based in high street optometry practices like Specsavers and Vision Express and all the others, many available, many optical businesses available. Okay, that's really helpful. So Rupal, how does an ophthalmologist differ then? What's the difference between you and Yuan?
So thanks for that lovely summary, Yuan. So what a lot of people don't realise is ophthalmologists had to train as a doctor first. So we study medicine and then we do general medical jobs before we do another 7 to 10 years specialising in ophthalmology. So you might say, why is it so much longer? And that's because we have to train in not only all the eye anatomy, but in operating. So operating cataract surgery, doing injections in the eye, so all aspects of eye health and treatment. So many ophthalmologists also specialize in different parts. So some might specialize in macular degeneration, whilst others might specialize in the front of the eye, such as corneal problems. And we do work very closely with optometrists, but as Yuan said, ophthalmology is more the tertiary care where patients who are more complex need more input, or maybe surgery, they come into the hospital to be treated.
Okay, perfect. That's lovely. Thank you very much indeed. Now, to crack on with some of the specific questions, we've got quite a lot of questions which are around issues like I have been diagnosed with dry AMD. How will it turn to wet AMD? I have it in one eye. Will it affect the other eye? And if so, how soon? My sister has it and her conditions progress very quickly. Will mine do the same? So a little bit, perhaps Rupal, a little bit on you know, what's the pattern that we would expect to see with macular degeneration in terms of conversion to wet, second eye, and the likelihood, or the raised likelihood and risk if you have a close relative with the condition? What's the picture that we understand to answer some of those questions?
So we know macular degeneration is very complex. It's a mixture of genetic factors and what we call environmental factors. So there's little we could do about our genes, what we inherit from the family. So if a sibling or a mother or a grandmother have had macular degeneration, you yourself are at high risk of getting it. There's other factors that make it high risk or more aggressive, such as being a lifelong smoker, living in countries with a lot of sunlight, having a lot of UV to light. So people with more pigment, more melanin, darker eyes are protected a little bit more than more pale skinned people with lighter, bluer eyes. So it's a combination of factors. We know now from the ARID study that diet has a big impact on macular degeneration, and having a really good Mediterranean diet rich in oily fish, green leafy vegetables, kale, broccoli. You can even get vitamins rich in xanthine and lutein. These vitamins can reduce your 10-year risk of getting macular degeneration in your other eye if you've already got it in one eye, or reduce your lifelong risk if you know you've got some very early changes. You asked what I would see. So you would, classically, people would see very early changes. This would be diagnosed by the high street optician or optometrist or the ophthalmologist when they've come for something else. And then this would progress slowly. In the past, we didn't have the techniques available now. So now there are these scans called OCT scans that are available in most high street optometry practices and also in all hospitals, which allow earlier diagnosis of macular degeneration, which in the past, your parents or grandparents would have suddenly presented with loss of vision, but now we are diagnosing more people and earlier.
So in terms of, so there's a genetic component to this. Smoking is very bad for your eyes. And I think the Surgeon General of the United States now says that there is a definite causal link between smoking and macular degeneration. And if you have the genetic predisposition and you smoke, then you're putting yourself in a pretty difficult position. We have lots of questions about nutrition and supplements. Yuan, do you advise supplements? Do you recommend supplements when you have people coming to your practice?
Yes, I do. Yeah, because I mean, when I was did my undergraduate dissertation, I did my study on the dry AMD, which I did quite a lot of study on supplements, and they are different research has shown that supplements will slow. Correct me if I'm wrong, Rupal. So there are different studies saying that it can slow down the progression of the degenerative changes for the back of the eye. But what I normally say in the primary care level of setting is that we see that the supplements that you have to discover yourself. So basically, you can go online, especially the Macular Society website. I sometimes go there to see myself what supplements is good for the patients from the ARED1 and ARED2 studies. But I think more information, I believe Rupal can give to the patient directly. I think on the secondary care level, if you see a consultant in the clinic. But in my clinic, I would say, yes, you can look into it and it can help you to slow it down.
He's asked whether it's okay to have these off prescription, otherwise you can just buy them over the counter. I mean, there is an AREDS formula, isn't there, which is often recommended. This is it contains 10 milligrams of mesozeaxanthin and lutein, 2 milligrams of zeaxanthin, vitamin C. That looks very much like the recommended AREDS formula, and in fact most people you can't get it on prescription. They won't will it now. You have to buy it over the counter. So, but it's safe to do so. Is that right?
Yes,
Yeah.
it is.
Yeah.
Also, the prices vary. So even though I do advise all my patients to have it, there's some patients who are already on a fantastic diet. You know, they have fish 2-3 times a week, lots of vegetables. Some people do struggle with taking the tablets. Either they can't tolerate it or they can't afford them. They can be expensive. They range from anything between £10 to £50 for a 1 month supply. So it can be financially a lot for patients. And, you know, I have to assess all the risks. And if they're generally really fit and well, have a family history, but have a really good Mediterranean diet, then I might say it's fine, you know, as long as you carry on eating lots of greens and broccoli and spinach and things like that, and the fish.
Kale. People often go, oh no, kale, I can't stand kale, but with a little bit of butter, a little bit of lemon juice, it's actually quite nice. Bit of bacon fat is quite nice actually. And I think the fat helps make the lutein a bit more bioavailable. It makes it easier to absorb the lutein. So that's good. So in terms of if you have macular degeneration in one eye, what's the chance of it developing then in the second eye? Rupal.
So, well, this is also part of the ARED study, which showed that patients who've been diagnosed with wet macular degeneration have a risk of developing it in the second eye over the next 10 years, which is why this formula was created to try and help reduce that 10-year risk. But another reason for us monitoring these patients, either in the hospital setting or via the optometrist long term, is because of this risk of the second eye getting the macular degeneration. Okay,
jolly good. Several people are asking about cataract. So obviously, given the age population of those of us over 60, we start to develop cataract as well as other conditions. There is still confusion, I think, among patients whether it's advisable to have your cataract operation if you also have macular degeneration. What's the latest evidence on this, Rupal, do you think?
So, Kathy, it's funny this question was asked because about 6 months ago, I decided to look into this as well for my patients. There's also conflict among ophthalmologists, and I don't know if there is among optometrists, about cataract surgery and macular degeneration. There's lots of papers out there, scientific papers, and if you look at them, they've got different results. Some say that cataract surgery increases the risk of dry macular degeneration progressing to wet macular degeneration, because cataract surgery causes inflammation and increase in what's called a VEGF drive. And we know VEGF predisposes you to getting those new blood vessels growing and causing activation of wet macular degeneration. There's another whole series of papers that say patients who've got macular degeneration, they may not have been diagnosed, they present with drop in vision, and then they have cataract surgery and you have a clearer view of the retina and you diagnose it. If my patients already have macular degeneration, I do not stop them from having cataract surgery. I arrange a sequence of injections. I arrange the operation. I may even inject them on the day of the operation, and then I follow them up with injections. Or if someone else is doing the operation, I get them to do the operation. I see them within 2 to 3 weeks to arrange injection. So in the past, we didn't know a lot about the disease and we were afraid to do cataract surgery. But now I'm very happy to combine both treatments of wet macular degeneration and cataract surgery and slot the surgery in and continue the injections. And it gives the patients the best visual outcome.
I think I've heard that now from quite a lot of ophthalmologists. So I think patients who are concerned about this, I think talk to your ophthalmologist about it. But I think the view generally now is that it's safe to have the cataract done. So we've talked about injections. Of course, we know that people have injections of this anti-VEGF drug to stop and slow down or prevent the growth of these normal blood vessels. But as a question points out, there are lots of stories about people leaving hospital after receiving a diagnosis of AMD and being told nothing can be done, goodbye. Why is this the case? Now, Yuan, I think that probably falls into your daily work. Probably you're telling patients this all the time.
Yes, I'll probably directly say nothing more can be done and goodbye. I think that's a pretty
good. Thank you.
pretty kind of rude way to tell the patient that way. But it's sometimes in the primary care settings, especially sometimes when I work in a hospital, I do tell the patient in a slightly different way. It depends on what the patient gets. So if the patient gets some very early stage of the disease, for example, like they come to my clinic and they I find some drusen, some very early changes for the back of the eye. And I'll just tell the patient, look, you have this, I can see at the back of the eye, and there's some age-related changes for the back of the eye. What we're going to do is going to monitor it. Okay, I don't say that, oh, there's nothing needs to be done. Okay, and rather than just sending the patient away, I give patients some solutions. For example, okay, I'm going to give you this chart, which is the Amsterdam chart. I'm going to tell you what time you should be worried. For example, if you see more distortions, or sometimes you see a sudden change in terms of vision, distortion or anything, you need to be aware. So I think in this case scenario, that when you see someone in the early stage of the disease, it's good to let them know, first of all, okay, what is going on. The second of all is to raise the awareness, how to prevent from further kind of changes, or if there's the changes, how are you going to deal with it? But in some other cases, I would say, you know, especially for the dry AMD, we're looking into it. There's no effective treatment at this moment. Well, in that way, I won't say, okay, goodbye. There's nothing can be done. And also, I'm going to explain what is, you know, AMD and everything to give, you know, general advice. But, you know, however, in one word, you know, what I'm trying to say just now is, you know, in fact, there is nothing to be done, but there's different ways that I can look into it and different ways to interpret it. For some patients, if they have, for example, like a very late stage of the dry AMD, I would be giving the patient options there. For example, you can look into some low vision aids options to help to see slightly better, to improve the quality of life, or for some patient who is really struggling with the mental health, to get some counseling support, to speak to someone in the hospital, or if, you know, if they're interested, there are always some research about new development of the treatment for the dry AMD. So there are clinical trials and everything, you can look into it. So yeah, so really, if I see a patient who has, you know, some conditions that we can't really do anything, I think let the patient well informed is very important to do, and to give patient options and further steps is very important as well. Yeah, so I would say that's the case. First of all, no treatment. Second of all, you don't need to be treated because it's very early stage. All we need to do is monitoring.
So these are mostly the people who are not treated at the moment, the people who either have very early disease, or they have dry macular degeneration, a condition that for which there is no treatment available in the UK at the moment. Now there is a treatment coming down the line that's already licensed in the US, and we hope will come here, which will be the first licensed treatment for dry macular degeneration. Rupal, when do you think that might, when we might know whether that's going to become available here?
So when I went on the recent international meeting, they're not looking to have it apply for the permissions till the end of this year, so maybe next year. However, the research on the treatment, there is some doubts whether NICE will approve it, and Kathy, you might be familiar with, it's a good treatment and it's the first thing that is out. So there is good news for all those people with macular degeneration, that we are looking at research and we are looking at treatments. However, this is the first treatment and it isn't perfect. So it really depends whether NICE considers the side effects profile as safe enough to be allowed to be given in the NHS setting.
There's some suggestion that it can increase the risk of wet AMD, is there? I think that's one of the problems.
Yes, together with some other risks.
So if we just talk about dry AMD, so we've got quite a few questions here about the progression of dry AMD. We start with drusen. So these, and this is in the case often with wet AMD as well. Drusen are these little deposits of fatty waste material, protein waste material at the back of the eye, which are thought to accumulate as part of the aging process. But then at some point it tips over from normal aging into into disease. Is that right? Somebody's asked, what's the difference between hard drusen and soft drusen? Come back to that in a minute. And then there's this slow progression with dry AMD. And then we're beginning to use this term more generally now, geographic atrophy, which is the shape of the scarring or the scotoma, is that right, on the macula. Does that always happen, and how quickly does this happen? Is it predictable, the rate at which this disease progresses? So I don't know who wants to take that first. You've probably both got experience of this. Yuan, tell me first what's your view of that? There's a whole cluster of questions in this area.
I think I'll leave this question to Rupal. She's a specialist in the OMR. I think she will get more information about the drusen, but I do, it was a question, the progression. Maybe I'll just leave it entirely to Rupal, actually. So it'd be very good at explaining this.
So I can't see. So basically, with regards to macular, the atrophic scar, so not everyone develops atrophy. You can get drusen. Classically we used to say soft drusen, hard drusen, and then talk about few, numerous, multiple to determine the risk. We don't often talk about soft, hard drusen anymore. There have been studies recently, again, at this international meeting I went to, looking at geographic atrophy and progression. And again, you can't, often I see people at 6-month intervals and say, has it got worse? Have my eyes got worse? And that's too soon. These large papers have shown progression by looking at images over 10 years. So you get tiny bit of progression every year, which is very difficult to see clinically or even on the OCT scans. But then patients say, well, I could see fine, and my vision suddenly dropped, because sometimes what happens is your central area, where the fovea is, you have the highest concentration of these cells called cones that help you see. And you may still manage something called 6/6 vision or 6/9 vision, which means you're seeing all the way down the chart. However, you have got a big loss of vision around the mid-periphery. And if you lose just a few cells in that center, overnight, the patient could feel like they've lost a lot of vision, and they could drop several lines of vision on the chart. So to answer the question, geographic atrophy usually declines very slowly. We do see there are some factors that are involved now that we know. It's a new finding, and we know that although people may be deteriorating very slowly, once these factors are switched on, sometimes patients can suddenly start to decline. So they are doing more research on this. And not everyone,
isn't it? It's a bit, everybody is slightly different. It's a bit difficult to say to somebody, you will lose your vision, your central vision in two to 3 years. It's quite difficult to predict in that way.
Although they're looking at AI, so these algorithms, automated algorithms, to try and predict it. And again, it's good news. It's all research, and we'll probably know more in the next 5 years. But at the moment, all the scientists are looking into it. Not everyone will develop geographic atrophy who's got wet macular degeneration. They may not develop any scar. They may develop something called a disciform scar. And some people can develop atrophy, especially with one of the drugs that came out recently called Beovu. That was shown to cause a little bit more atrophy than the conventional drugs that we use, like Eylea and Lucentis.
Okay, thank you very much indeed. So, I mean, somebody does say, what exactly happens during GA? What's going on in the eye? And this is really just the cell death, isn't it? It's the death of the photoreceptors, the seeing cells of the eye. And that's all that's happening, really. It starts just to make an impression. You can lose quite a lot without noticing, but it gets to a point where you start to, it starts to impact the vision. A question here, Yuan, about when should you go and see an optometrist? And how does an optometrist help somebody with macular degeneration make the best of their vision?
So I always tell the patient that you should see an optometrist if you have or if you don't have any eye problems. So I always tell anyone I know that you need to see an optometrist every year or two. But for someone who has a macular problem, It depends on what disease do you have. So it really depends on the record time. So basically, if it's in the beginning of the disease, maybe we can extend the review time a little bit longer. But in some other cases, we might not be able to manage this patient in the clinic. We might need to refer the patient to the hospitalized service. So I would say for the general public, if you think that your eye is experiencing something that's unusual, especially if you see any distortions, some new distortions, or any other weird symptoms that you can experience, go to see an optometrist as soon as you can. But bearing in mind, if you have something really you think is an urgent matter of your eyes, you need to go directly to the A&D department. For example, if you have really painful eyes and you're seeing halos sometimes rise really red and painful, this kind of cases, maybe it's slightly better to go to see an eye department emergency rather than seeing an optometrist. But in the ideal world of practice, in my thoughts, I think all the patients should be triaged by optometrists at the beginning. And then it depends on the severity of the case. They'll be managed at a primary level, or they need to be referred for the hospitalized service to further care. So yeah, any problems, come to see optometrist.
But I think also we always say to people that you should go, as you say, you don't wait till you think I've got something wrong with my eyes. Go anyway, because you're going to look at the health of the eye. You can even pick up other conditions like high blood pressure, can't you, and things like this by
exactly. So basically,
go at least every 2 years, and I think after a certain age it's free. So you're not even having to pay for it, are you? If you're over 60, I think.
Yeah. There's some criteria you can get free eye tests. You can have a look online. It's explained quite clearly online. But I just want to add one point: is that some of the eye problems you won't notice at the beginning. For example, like glaucoma, some early stage of the dry AMD. If you have a family history, especially, that's something that you have to bear in mind. You need to get your eye checked. So yeah, otherwise, if you have symptoms, sometimes it might be the end stage of the disease. So you don't want that to happen, especially for some of the disease, you can't really fix anything once the damage is there. So yeah.
And in terms of fitting glasses, then for people who are in a treatment, in the middle of treatment, how do you judge that when it's going to be right to prescribe?
This is the question I normally get asked in the clinic. So when do I see a optometrist for new prescriptions? Sometimes, after injections, sometimes they receive, other different treatments. So my advice is in general, I advise patients to see an optometrist to get the prescription when the injection circle where your vision is most stable. But to be honest, I want to hear some advice from Rupal as well. What do you recommend patients to come to see us as an optometrist? But I normally say that when the vision is stable, we normally tend to get a pretty good result for refraction. So we can give you a pair of glasses if you need to wear glasses, and then hopefully we can, our purpose is to let you to achieve the best vision that you can see with the glasses. So yeah, I actually want to hear what Rupal think about when you send in patients to optometrist in between treatments.
So thanks for asking. I completely agree. I like the way you phrased whenever you're in the most stable process. A lot of patients may have injections every 4 weeks, 6 weeks, 8 weeks, 12 weeks. So once they're on a defined pathway, and if they do need glasses, then I would normally say a week or two after the injection. So if they're on a 12-week pathway, they've had the injection, it's been 1 or 2 weeks, there's no risk or very minimal risk of getting infections in the eye, and they have glasses, and that time they'll be fluid free. So the macular degeneration will have been treated. What I do always say to the patients is sometimes they're not aware that the consultant is planning cataract surgery in between. So when I see them very early on, I might say, do not go and get glasses done until I tell you, because my plan is to start the injection pathway and then operate on their cataracts halfway through and then carry on the injections. And doing the surgery may make them AMD worse. And I don't always tell the patients all the information because there's a lot to take in on the first consultation. The news of them having wet macular degeneration, them needing injections, then they may need cataract surgery. It's too much. So sometimes I like to break it down into a few consultations and give the news slowly. And then by that time, the patients know what to expect with the injection, the treatment, and it's not so much to handle.
Brilliant. Okay, thank you very much indeed. Now, I just want to go back to a couple of questions about treatment. So wet AMD treatment, there's now a range of drugs, isn't there? There are 3 or 4 drugs that clinicians can choose from. So first question here is, if I've been diagnosed with wet AMD, how long after that diagnosis would somebody start treatment? Here's a question, Rupal, for you.
So ideally it should be 2 weeks. And in fact, when from referral, we always, if we get a referral query, wet macular degeneration, we say urgent fast track macular 2 weeks. But it's like it's similar to cancer pathways. We have a tight timeline. And when I diagnose, on the listing, I always say within 2 weeks. And at my unit, I'm very lucky that my patients do get injections within 2 weeks, sometimes 1 week or a couple of days. Unfortunately, due to the demand in the NHS, it doesn't happen everywhere, just because there's so many patients needing the treatments.
It's a bit of a postcode lottery, isn't it? I'm afraid.
Yes.
So the next question on this is some people get injections, as you mentioned, every 4, 8, 6, 12, 16 weeks. Why is it different?
This depends on how aggressive the disease is. We mentioned earlier about risk factors, genetic and lifestyle. So the risk factors determine, and the nature of the macular degeneration show how often the injections need to be. Some people aren't what we call dry at even 5 weeks and they need injections every 4 weeks. Some people may be dry with the same drug at 12 weeks. You did mention there's lots of different drugs now, and so we are able to try one drug, try 4 to 6 injections. If it's not working and we can't extend the period, so make them go up to 6 or 8 weeks, we could change the drug and change the drug again. So we're lucky now that we've got a few options, and some people do better with one treatment rather than the other, even though they all work very similarly.
And the newer drugs tend to last a little bit longer, don't they? They seem to have a slightly longer action of period of action in the eye, and that's a big holy grail, isn't it, really, to be able to extend people out, because who wants to go every 4 weeks and have a needle jabbed in your eye? It's no fun at all, is it? So the longer the strain on the patients and also in the NHS, if you can extend that. So I think some clinics will try and say, well, let's see how you go for 10 weeks and just try. It's called treat and extend, isn't it? The regimen where you just try and see if you could push the treatment intervals out further and further, so that people don't have to go so often. Another question here: who will do my injections? Who does the injections? Yuan, optometrists very often do them in clinics now, don't they? And nurses. And are you an injector?
No, I don't inject myself. I think most of the injections are done by in the hospital I work at, Western Eye Hospital. We have advanced nurse practitioners, so they do the injections. So they have to inject about quite a lot of people a day. Some optometrists, if they're trained, they can do the injections, and ophthalmologists, sometimes if they're trained, they can do injections as well. And some of the doctors, they do injections for the clinic. So it really depends on who you're seeing on the day of the consultation, and who's on the shift doing injections. You may see different varieties of ophthalmic professions doing your injections, but they're all trained for doing the injections for sure. So yeah, I think if you go to hospital, it's in safe hands for injections.
All these non-doctor injectors have to be supervised, don't they? So I think
yes, first of all, they have to receive training, and they have to get certain competencies for that until they're safe to do the injections themselves. And obviously, if you come to the hospital, we work in a very big team. We take care of patients all together. So there will be someone, monitoring or supervising whatever to make sure that the patients are safe.
Rupal, there aren't enough doctors to go around. It was originally only doctors who are allowed to give these injections, but there are so many patients, there simply aren't enough doctors in the world to do it, are there?
Well, the nurses are excellent. In fact, my father doesn't mind me saying, He's had over 40 injections, and he's had consultants do them. He's had middle grade doctors do them, nurses, and he prefers the nurse. And there's, he always says, I want a nurse doing it, because they do so many, they do them day in, day out, and they're excellent. They don't multitask like the optometrists and the ophthalmologists who are busy doing clinics and surgery. That's all they do, and they become very efficient at it, and they're very good with the patients too.
Yes, I've heard that as well. That's marvelous. Now, this is a question which it is very specific, but I think we ought to address this, because I think this may be at the back of a lot of people's minds. So somebody who's talking about the likely progression of wet macular degeneration. Of course, it's difficult to predict. We know that. Having Eylea, which works better than for her than Lucentis. But this is the part of the question: will I lose my sight altogether, or will I retain some vision? I have it in both eyes, and I know this is a fear at the back of many people's minds. Will they lose all their vision? I mean, we say the answer is no to that. Rupal, and both of you. Rupal first.
So Kathy, in fact, when we consent patients, so we have to, before we ask patients to have an injection, we have to get them sign a legal document to say they are having injection X, so Eylea, and the risks. And one of the things we have to tell patients on that is, this is not to save your sight, this is to delay sight loss. So the way I can never tell them, some patients do excellent and they actually regain the level of vision they had. However, I cannot tell them that, excuse me. So the sight loss, they may get a little bit of sight loss over time, but some people maintain a good level of vision for over 10, 15 years. It really depends on them getting frequent injections. And also, if they do lose vision, it doesn't all go black. They lose that central vision. They might get a central scotoma, but they retain the peripheral vision. And this is really important, because patients can function with peripheral vision. They can go out, they can dress themselves, they can do a lot. Whilst other diseases we see, patients would lose peripheral vision. So the good thing about macular degeneration, if you are going to look for the silver lining, is you do not lose all your vision as is thought.
So the central vision, Yuan, you retain the peripheral vision, which, as you say, Rupal, is very useful for navigation, isn't it? So and people can learn to use a little bit of this. We call it eccentric vision. So often they'll have a little part of vision, which is, so the most of the central vision is gone, but they can learn to use, and we actually coach people to do this with using volunteers and staff at the Macular Society to help people identify another little bit of vision. We call it eccentric vision, because it's not the central vision, it's the eccentric vision. It doesn't mean that you're eccentric as a person. And that often can help people with sort of, we call it survival reading, where people perhaps won't be able to read anymore. Yuan, do you advise the use of eccentric fixation and things like this?
For the eccentric view, I think it's quite important for patients to get training on this. As optometrists, like we do run a low vision clinic. In some cases, we see patients in the low vision clinic. They have a central vision not very good, but they have a perfect kind of vision on the periphery. And so for those patients, most of the cases, they're really happy about their peripheral vision. And after some trainings in the low vision clinic, they can see, they can read, and they can feel safe to move around. So I would say for someone who has a quite, central vision is not very good, is good to look into the training sessions to train how to use your peripheral vision. I believe the Macular Society, they do this training. So I believe, is there anyone needed, just go online. If you search that, and you'll be able to find help from the Macular Society for sure. If anyone's interested in finding out more, then please do call our advice line, our helpline in the morning, 9 to 5, 5 days a week. You can call them. The number, and we'll put it in the chat, is 0300 30 30 111. 0300 30 30 111. We'll put it in the chat, and I'll give the number out again, and they will be able to refer you and put you in touch with the eccentric vision coaching team if that is going to be of interest to you. So the answer to your question is, macular degeneration will not make you go completely blind, and people fear that, I think, very, very considerably. So thank you both for those answers. Here's an interesting one.
about lighting. So we know that as we age, we need more light. You need, I don't know how many times, 4 times more light to see at 60 what you could see at 21 or something like that. But actually good lighting is critical for macular degeneration patients, isn't it? Yuan, do you want to talk about that?
Exactly, I do agree with that. And in terms of lighting, I think lighting is something to help you to see better. So most of the patients come to my low vision clinic, they have certain tasks to, but most of the patients, they come to me and say, okay, Yuan, I think I want to read something, or I want to use my telephone, or I want to see my computer screen. So I will always say that lighting is very important. And there are 3 things that you can do to help you to read and do certain tasks in terms of lighting. So always use the natural lighting if you can. So this is what I was told by a professor from the university, and she's really, when I was having a lecture, it's really saying that if you have someone who has a low vision, lighting is very important. Make things brighter, bolder and larger can help you, but lighting always comes the first. So when you get indoor, try to secure so when you read, try to stay next to the window. That'll help you to see slightly better with the natural lighting. Or if it's during the night, find a lamp, use the direct lighting on the resource that you're reading. Can always help you with, seeing better. So I think that's my advice for lighting. It's very important, and it will make a big difference if you use a good lighting to see. So it is very important.
We have a great leaflet on this, which is, you can find the pages on our website, or you can call the advice line and they will send you leaflets on lighting, on how to light generally around your home in a safe way, so you don't create shadows and corners which are a bit dark and so on, and also the use of task lighting and all the different nuances about how bright the light is, what color the light is, and how to get something that really suits you. So they're a great source of information. So give them.
Just say one thing very quickly. So if you're struggling with the lighting, go to see optometrists. This is a time that you need to see optometrists as well. They'll be able to help you with lighting, how to see better, and all those kind of tasks.
Yeah, that's great advice. Good. So a couple of questions now about light in a different sense. So a question about, you mentioned, Rupal, about the effect of UV light. Somebody has asked, should they wear sunglasses indoors? And somebody else has asked about whether using a lot of being on the computer all the time, and smartphones and tablets and blue light, whether that is a danger for macular degeneration. So blue light, first of all, use of computers, and then secondly, is it sensible to wear sunglasses? We all say outdoors, even perhaps on cloudy days, to reduce glare, apart from anything else. But also indoors, should you wear sunglasses indoors? Rupal, what do you think?
So I'm really passionate about light because, as you mentioned right at the beginning, my research was about sleep and wake. And we know light affects sleep, especially blue light, lack of it. In this country, we don't get enough light anyway. Firstly, I'd say no to wearing sunglasses indoors. It's more the UV damage from sunlight. And I saw a question pop up about sunbathing, things like sunbathing are very bad. And also years ago, 60s, 70s, people didn't wear sunglasses in the summer. They didn't wear sunglasses when they sunbathed. So if you're going outdoors on a sunny day, wear sunglasses. I sent so many of my patients to the optometrist and say, you can get your glasses, but when you do, please get photoreactive lenses, because that way they will naturally get tinted with the light UV levels. So no, don't wear sunglasses in the house. Blue light, you get blue blocking things and blue light filters. However, you do need this blue light to help you sleep. And there's a lot of research we were doing while I was in Oxford on blue light and how it affects your sleep wake patterns. So I'm not generally day to day, I think a patient should be able to live a normal and healthy life as long as if they're smoking, stop smoking, have a really good Mediterranean diet, take vitamins if they can afford it. And yes, try and avoid a lot of sunbathing, wear sunglasses, and then I don't really go into the little points about UV filters in the house. a blue light
No,
filter.
I don't think there's any great evidence, is there, that computer use is connected to macular
No.
degeneration. There's no evidence of that.
No.
So I think you're all right. Stay on the webinar. That'll be fine. Very important question has arisen here. When should you report your sight issues to the DVLA? And this is often the driving licenses, loss of driving license is often a watershed moment for so many people, isn't it? It's a real time when they dread coming to them. Yuan, what do you say to people?
Yeah, so normally the DVLA test for driving vision is done in the optician, but when I work in the hospital, I realized some patients, they're in the hospital setting and they were diagnosed with some eye problems and their vision is affected, but they do not go to see their opticians. So they've been managed in the hospital all the time, and they thought, okay, my eye's been looked after, and everything should be looked after here. I don't need to go to the optician. I think that's wrong, because especially when sometimes the vision is reducing with the time. For example, 6 months later, the vision's reduced a little bit. Another 6 months, the vision is reduced a little bit more. And that's the time I believe all the ophthalmologists will recommend to get the driving test done. So that will be done in the optician. So in the optician, what will happen is they'll do an eye test for the patient who asks for a driving test, and they do a visual field test. So after all the tests, the optometrist will advise you if you should notify the DVLA and how good your vision is, if you're safe to drive and everything. So my advice is, if you're being monitored in the hospital eye setting, you still need to go to see your optometrist regularly, especially when you drive. So you need to get your driving vision checked regularly, because first of all, you need to make sure that you are safe to drive. Second of all, is also for everyone's safety. So yeah, so if you're in a hospital being monitored, go to see your optometrist, get your driving test done, and because that's the time we work together with ophthalmologists to see if the patient can drive.
So you have this responsibility to tell the DVLA if your vision falls below the legal driving limit.
Yes, exactly. And also you need to report the conditions that you have to the DVLA, and there's a list on the government website of what condition you have. You need to report to the DVLA. So you must do it if you're having those conditions. But I think there was a drama a couple of weeks or a couple of months ago, and they updated the list of the conditions that you need to report. But I believe they fixed the list now, I think. Yeah, so if you go online, search what eye conditions I should report to DVLA, and you will see more information on the government website.
Do you have anything to add to that, Rupal?
No, I think that was great.
And we have a on this as
I
well.
think the one thing I want to say about the DVLA driving is, can you hear me? Yeah, sorry, is I do often get patients who will not report themselves, and I say you do need to report themselves, and because of the confidentiality, we cannot directly report them. We just can advise them. I also have patients who say, oh, but doctor, I don't drive far. I only drive in the daytime. I only drive to the shops down the road. If they are not legal to drive, whether they're driving from the house to the doctor's surgery down the road, it is not safe. And they are, like Yuan said, putting their lives at risk and other people's life at risk.
It's a terribly hard thing to do, isn't it? To make that decision when people often are so dependent on their cars, aren't they? We're so reliant on them so very often.
And also, if there is an accident that you're involved after you're advised not to drive, I think the insurance will not cover the accident. That's the other perspective of driving if you have eye problems.
Yeah. So I think the rule is that you have to notify the DVLA if you have a condition that affects both eyes, or only one eye if you only have one good driving eye. So if it affects both eyes, you must tell them. And if you fall below the driving standard limit, you must inform them, otherwise your license, insurance are all invalid. So it's a very important question.
So it's important to know it's not always about how well you can see, it's also about how wide you can see, the visual field.
Yes.
Of your eyes. So yeah.
Yes, it is. Thank you for asking that question. That's very helpful. Just for the last 10 minutes or so, I just want to look ahead because we've got quite a lot of questions about what's coming down the line. So somebody has asked a question about the Valida light treatment. So this is now being offered, I think, in some optometry practices. It's exposing the eyes to a certain wavelength of light, and the proposition is that it will slow down the development of macular degeneration. Do either of you have views about Valida as a useful treatment? Rupal first.
I have very strong views. So I actually looked at the research for this in detail. Unfortunately, I don't personally think a large body of ophthalmologists have looked at the research, and we do not believe there's enough data. I recently went to the last ARVO meeting, which is the American Research Vision meeting, and the trial was done during the COVID period, so they could only, I don't have the numbers at hand, but they could only recruit just over 100 patients. And the numbers were not large enough to determine whether this light treatment worked. And looking at the in-depth analysis, there was one patient also who had macular hole from it. And also looking at the analysis, I do not think there's enough data there to suggest it works. At this meeting, they were also selling the machines for ophthalmologists to buy them, and none of us bought them. So I would save your money just yet. I'm not saying it doesn't work. I'm just saying there's not enough evidence just yet. I don't think.
What do you think, Yuan? You're on mute.
Well, I agree with Rupal. I don't think it's widely used, especially in the, I don't know any practice doing that at this moment. So yeah, I do agree with Rupal about this.
It's a shame, isn't it? Because it would be a lovely solution, but we have to wait for more evidence, I think, at the moment.
Exactly, yeah, so I think it's very heavy evidence-based if we do anything in the UK. So yeah, so we need to wait a little more research about it to see.
What else is coming down the line then? We've touched on this new drug for dry AMD, pegcetacoplan. I think it's going to be called, I forgot the commercial name for it. Is it Syfovre or something? Anyway,
Syfovre, yeah.
Which is produced by a company called Apellis, and it is licensed in the United States, and they're preparing their submission to the Medicines and Healthcare Regulatory Authority in the UK for permission here, and that might or might not get through. But what else is coming down the line? Is there anything else bubbling away, Rupal, that you know? Did you hear of at this big huge ARVO conference thousands and thousands of ophthalmologists go to?
So there's been a lot of talk about in the past we did things like retinal transplants where we moved a bit of the healthy retina across. We tried extrafoveal fixation. There was the orthodontics, but now we're looking at a lot of treatments with stem cells. So looking at your own cells and looking at healthy cells, inserting into the eye to try and regenerate healthy retina. Same with gene therapy for macular degenerations. So there's nothing else new out at the moment, but they are doing a lot of research on these things. And like I say, for my patients with retinitis pigmentosa, there is a lot more out there with stem cells and gene therapy for your condition, as well as macular degeneration, but probably something that will be available for our children, I'm hoping.
And of course you have it in your family, so I guess you've kind of got a real personal interest in this coming up.
Yes.
A lot of interest in turning the injection drugs into eye drops, and in fact the Macular Society has been funding quite a lot of work to try to create eye drops. That would make a big difference to certainly many patients in the NHS, I imagine, too.
Yeah, that looks very hopeful, the eye drops, because they did look at other things, didn't they, of the implants that go into the eye that avoid the injections, which they're moving away from. But I think the eye drops are the next hopeful thing.
That would make a difference to people. Yuan, what's your, let me ask you finally what your big hopes are for the future for macular degeneration. Yuan, what's your dream scenario for the future?
I'm a technology guy. I think artificial intelligence will play a very important role in the treating the macular disease, especially Rupal mentioned to predict the progression of the disease. I think if you understand the progression a bit better with the help of artificial intelligence, I believe we will, see the disease in a different way, and hopefully will benefit for most of the patients. So I think artificial intelligence is very exciting. Also could be dangerous, but it really depends on how we use it in the medical field. So I'm really bright on artificial intelligence at this moment, but I'm waiting to see. Hopefully I can do a bit more research about this, because there's quite a lot of research going on in the UK, in the US, about how artificial intelligence can help us. But let's see. I think it's still a little bit too early about this, but I believe in the next 3 to 5 years, and there's so many new things, it will be introduced for the macular disease, especially with the help of artificial intelligence.
It's already helping produce diagnostic algorithms.
That's more helping us as a clinician, but I think at the end it would definitely be, the general public, the patient would be benefit from artificial intelligence.
Rupal, what's your big vision? What's your big hope for the next few years, do you think?
As you said, Kathy, I've got vested interest in it, and I really do hope for a cure. In fact, I hope that we can stop dry macular degeneration, progress to wet macular degeneration, because it's one of the biggest causes of blindness worldwide, even now.
It is now the third biggest cause, isn't it, of sight loss on the planet, and the biggest cause in the developed world. So it is a huge public health problem, and this is why we talk a lot to politicians and policymakers about rising it up the public policy agenda. Vision matters, and it's an important thing for people. Well, we've run out of time, but thank you so much. Thank you for all your questions. I'm sorry we haven't got to them all. You'll be able to see this again online, and recommend it to anybody in the next few days. We'll try and get it on before the end of the week, but we've got quite a lot of people on holiday at the moment, but we'll get it up on the website as soon as possible. You can then watch again, or as I say, recommend it to somebody else. I promise to remind you of the helpline number, 9 to 5, Monday to Friday. They are there. They are a huge source of information and advice, and if you didn't get your question answered tonight, then put it to them, because they will be able to help you. We've got a whole enormous range of literature that will also answer many of your questions. That number is 0300 30 30 111, and it's put there in the chat. 0300 30 30 111. 9 o'clock tomorrow morning, they'll be there to answer your calls. Yuan, Rupal, thank you both very much indeed for your time, so generously given to us and our viewers this evening. It's very kind of you. Your expertise is just marvelous, and I'm so grateful to you for all that you do for us. Thank you very much indeed. We shall be back with another My Macular and Me in August. I do hope you'll be able to join me then, but thank you all very much indeed for your company this evening, and have a very good evening. Good night. Good night.